Good afternoon, everyone, and a very warm welcome to you all. My name is Simran Chaudhary, and I welcome you all on behalf of Voice of Healthcare on the occasion of World Sickle Cell Day. And we are proud to present today's virtual session, the Sickle Cell Dialogue Unfolding the Future Innovation in Sickle Cell Care, brought to you by Voice of Healthcare and supported by AIIMS. We all know that sickle cell disease continues to pose a major public health challenge in India, especially in tribal and remote regions. Despite progress in diagnosis and treatment, there are still significant gaps in early screening, long term management, and equitable care access. And today's dialogue is about solution. It is about reimagining the future of sickle cell disease care through the lens of innovation, policy, awareness, and collaborative actions. And today we are honored to have with us exceptional panel of experts who are leading the charge in their respective domain. We have Dr. Vinita Srivastava from National Health Authority, Ministry of Health and Family Welfare, who has been pivotal in shaping the National Sickle Cell Anemia Elimination Mission. She'll be joining us shortly. Mr. Gautam Dongre, Secretary, National Alliance of Sickle Cell Organization, a powerful community voice and change maker. Welcome to our show, sir.
Thank you so much, ma'am.
Thank you so much for joining, sir. Dr. Manas Kalra, Honorary Secretary of the PHO chapter of IAP and Senior Consultant at Sir Ganga Ram Hospital with a strong clinical perspective on pediatric sickle cell disease. Welcome to our show, sir. I think there's some technical error because he was there, so he'll be joining us shortly with us. Dr. Gopal Patidar, Additional Professor, Department of Transfusion Medicine at AIIMS New Delhi, whose work bridges critical care and transfusion science. Welcome to our show, sir.
Thank you. Thank you so much.
Thank you so much, sir, for joining. And a big thank you for everyone, our panelists, our audience who's joining us today for this virtual discussion. And without any further delay, let's begin the panel discussion. I would like to start with Mr. Gautam Dongre. So, what are the key challenges in accessing hydroxyurea and ensuring its monitoring in tribal region, and how can we highlight its importance in resource-limited settings?
Thank you. It is a very important question because hydroxyurea is the only drug right now we all knows that which is very important for sickle cell disease. We can say that it's a life-saving drug. As we all know that our most of the people, most of the sickle cell warrior lives in a tribal and remote areas. So the main challenges of hydroxyurea in these regions are start from the healthcare professionals, as I can say that, because our patients' first contact is PSC doctor or district health doctor, because whenever they comes in a crisis, they go to the PSC medical officer or district health officer. So our challenge is the doctors, maximum doctors are not knowing about sickle cell disease diagnosis and their treatment. So in tertiary care and secondary care units, we are very sure that the doctors are in medical and AIIMS, they can get a full treatment. But about the PSCs and district hospital, there is a challenge that doctors are not, many doctors are not knowing about how to diagnose sickle cell disease or how to give the hydroxyurea treatment protocol to the disease. This is the main challenge, and because of that, many patients are not getting hydroxyurea from their PSCs or district health centers because the doctors are not prescribing to them. If some are prescribing, then there is a possibility to getting. There is no any issue of supply from the government side. The issue is that the demand side. The demand will create when the doctor will prescribe to the patients. This is the main challenge we are facing.
Thank you so much for answering this question, sir. And we understand that how important it is to aware our audience on all the aspects. Thank you so much for sharing your expertise on this. My question is to Dr. Gopal. So, what is the significance of transfusion medicine in comprehensive management of patients with sickle cell disease?
Yeah, thank you. So, like Mr. Gautam mentions, that hydroxyurea is a kind of the miracle drug for the sickle cell disease. So, other than hydroxyurea, what is most commonly required for the sickle cell patient is blood transfusion. Sickle cell causes the severe anemia in these patients. Almost hemoglobin drops down to the 4 to 5 grams per year. So the blood transfusion medicine role in management of sickle cell anemia primarily is simple blood transfusion to increase their hemoglobin. But in some cases, this simple blood transfusion can also increase the viscosity of the blood, and this can further lead to some pain crisis in this kind of the patient. So, in that way, the other modality which transfusion medicine can help in sickle cell disease patients are the red cell exchange. In red cell exchange, we remove the sickle cell from the patient's body and transfuse it the normal blood. So in simple transfusion, we just simply transfuse the normal blood, but in red cell exchange, we remove the sickle cell and then transfuse it to the normal blood. So in these two major ways, the transfusion medicine play a role in the management of the sickle cell.
Thank you so much, Dr. Gopal, for answering that question. And we just got an update that Dr. Manas Kalra is joining us soon. He's facing some network issue, but by the time we'll proceed, Mr. Gautam, I would like to know from you that how can community-based patient advocates improve treatment adherence and reduces stigma around this?
Yeah, thank you for this question. Uh, yes, patient community role is very crucial to advocate and aware to the common people for the improvement of treatment and reducing stigma. We as the National Alliance of Sickle Cell Organization (NASCO) we have already created our YouTube channel to aware the common people. We usually takes interviews of expert like hematologist, orthopedic, ophthalmologist, gynecologist, etc. So these experts we take an interview in a Hindi language and put all their suggestion on our YouTube channel. So by these media, we are regularly trying to aware and educate common people regarding what is sickle cell disease and what are the treatment right now available, so that it helps to the patient to know about their disease. So this is how we are trying to educate and empower sickle cell patient families and community. Also, as a patient advocate, we are every year organizing many webinars, seminars, state level conferences, national level conferences, and we try to include all stakeholders there. And by that, we try to educate and empower all over the people, those who are stakeholders and directly can give the benefits to the sickle cell patient. So this is how we, as a patient advocate, we are trying to educate them with our YouTube channels and monthly webinars, seminar. Also, we have created multiple support group, WhatsApp support group of each and every states. We have 17 states sickle cell disease, but out of 17 we have at least 11 states support group, and in this state wise there is a district wise also support groups are available. So in this group we are directly counseling to the patient and try to refer them in the in to the better doctor, to the better education about their concern. So by this support group and YouTube channels and all these videos, also we are uploading the videos of sickle cell warrior success stories, so that we could now reduce some stigma from the community, because as you all know that sickle cell disease is associated with lot of stigma. So simultaneously we are working for stigma and treatment both offline. Thank you so much.
Thank you so much, Mr. Dongre. And now Dr. Manas Kalra has also joined us. He's the Honorary Secretary of the PHO chapter of IAP and Senior Consultant at Sir Ganga Ram Hospital. Welcome to our show, sir. Thank you so much, sir. Sir,
Hi, good afternoon.
good afternoon, sir. We would like to know, with curative approaches like stem cell and gene therapy advancing, how do you envision their role in the standard treatment landscape for children with SCD in India over the next decade?
So, as you understand that, sickle cell disease can be quite a crippling disease. Patients who suffer from homozygous sickle can have a lot of problems in their life. If we are not managing them properly, if they are not responding to hydroxyurea properly, some of these children actually need regular blood transfusion, change transfusion. They can have recurrent painful crisis. They live life in pain. They are admitted again and again. They can have pneumonias, infections. They can have sickle cell where their liver can be affected. They can eventually have damaged kidneys. Many organs can be affected. Now, there are some of those children who respond very beautifully to hydroxyurea. Their hemoglobin is above 910. They are not having much of pain. They respond very well and they are very happy to just observe them on hydroxyurea. But those who are poor responders, those where access to regular care is not there, who are not very motivated for regular checkups, there are times when we wonder that these patients, is there a one-time solution? That one-time solution can be through a bone marrow transplant. Now, the bone marrow transplant is becoming safe by the day. If a homozygous sickle who has a lot of symptoms has a brother or a sister who is a complete match, we advocate them to undergo a stem cell transplant to cure this condition. If there is no match, then again, we have to weigh the benefit and the consequences of doing a stem cell transplant, because the risk of complication with mud transplant and haplo transplant can be more. So we have to see whether the sickle is causing more problem or whether the transplant will cause more problem. When the patient, somebody will say, oh, they don't access regular health care, so let's do a transplant. But even after a haplo or a mud transplant, they need to access a regular health care. So, it's easy to say and just do it, but these patients who undergo a transplant also require a regular follow-up. So yes, if there is a match sibling, definitely go ahead, do a transplant if you're symptomatic. And if you don't have a sibling, then we need to discuss with the family about haplotransplant, mud transplant, complications associated. Discuss, take the family into consultation. It is becoming safe by the day, so I'm sure that we'll be able to offer transplant to more and more patients. But we have to acknowledge the fact that transplant is not cheap. There's a lot of expense to it. There is a risk to the life while we do it. So all those risks have to be explained to the family. Now, coming to gene therapy, you asked, your second question was gene therapy. At the moment, it is not available in India. A
Okay.
lot of work is going on. A few gene therapy patients have undergone, few hemophilia patients have undergone gene therapy in India. That's also in very early stage. So we are very far from the reality. I think the scientists, the researchers need to do a lot of work to bring gene therapy to India, to a common man in an affordable price, when we'll be able to offer to every patient.
Thank you so much, Dr. Kalara, for answering that question.
I hope I have
Uh,
answered the question.
Definitely, sir. Yes, we got a great insight on this, sir. Thank you so much. Now, my next question is to Dr. Gopal. Sir, what are the key challenges in ensuring that accessible and effective transfusion services for the sickle cell disease patients in our country?
Yeah, thank you. So, in current status of the blood centers in India is almost 4,500 blood centers. But these blood centers are primarily located in the urban areas or tier 2 cities. And you can see the sickle cell prevalence is most in the tribal area. So the primary challenge is the availability of the blood. So blood, they cannot travel to so much long to reach any center which provide the safe blood for the transfusions, and the blood cannot reach to them for at their BHC level or CHC level, you can say. So the availability is the primary key challenge. Then the second key challenge is there is recommendation that before first transfusion of the any this kind of the patient sickle cell or thalassemia, we have to do the extended phenotyping of that patient's red blood cells. In extended phenotyping, we are typing normally ABO and RH blood group, but other than that, there are many other blood group systems like Cal, KID, Duffy, MNS. If we do the extended phenotyping before first blood transfusion, we can able to provide blood if in future in the patient develop allo antibodies, and we can easily identify which allo antibody patient develop, and we can easily able to provide. But this extended phenotyping facility is also not available in all the blood centers in the India. It is available in the major centers like you can say my center or some PGIMEA, Chandigarh, or in south some major centers is only available. So these are the two key challenges to provide safe blood to these patients.
Thank you, Dr. Gopal, for that answer. My next question is to Mr. Dongre. So, what role does culturally rooted awareness play in encouraging families to seek timely diagnosis and care, especially in case of people with known or unknown status of sickle cell trait? Sir, you're on mute.
Yeah, thank you so much. Yes, the cultural activities plays a big role to aware the community. As I earlier told that it's a disease where mostly in tribal and remote area. So every district's tribal's language differ from other district tribal people. So there is a challenge we are facing to communicate um, the last people, and as the community based street play or road play, we can say that, or community gathering, these are the very important ways by which we can aware uh, these people with their languages, because we generally experience that outside people when enter to the any tribe area, so they not accept easily to these people. They fear about these outsider. That's why um, the people from their tribal community, their community, these people are very important to aware them. And by the plays and local plays and street play, we can uh, aware them about genetic counseling and how it's spreading after marriage, and what is the importance of testing before marriage, and how the child uh, births with the sickle cell disease. If they people try to understand them in their language, then the tribal people can easily take it as, and then we can see the change of genetic counseling there, and we can stop the new birth, and also we can provide them uh, a better life with the medicine available. Because I want to just mention that the stigma associated sickle cell disease, mostly people goes to outside without medicine line, like baba and jhad phuk. So these are very common in tribal people to treat sickle cell disease, but the mortality is very high due to this wrong treatment. So the need is a proper awareness in their local language with the use of plays and cultural activity. Thank you so much.
Thank you so much, sir, for shedding light on that aspect. My next question is to Dr. Manas. Sir, how can genetic counseling be strengthened as a core part of our SCD care in tribal regions, especially with the individuals with sickle cell trait to support the informed reproductive and health decisions?
See, the best way to do is education. Abhi Gautam Dongre ji just now told that how you can involve the people from tribal community, and when they speak to their fellows, it is always better. We have to set examples. We have to bring those people to meet those individuals who have undergone antenatal testing, who have undergone, termination of pregnancy safely. So that awareness has to be created. Now we have to get people to. There is so much stigma associated with this, and there is so much less education in that area. So only way to promote this is by educating people, by setting examples in front of them, by continuously using social media platforms to motivate them. The whole day people are sitting on Instagram and Facebook. Why can't we advertise about prevent sickle cell birth of a sickle cell child? If there is a sickle cell, what are the precautions? Avoid dehydration. Use the power of celebrities. Call the celebrities, involve them in the sickle cell campaign. We have to do all these things. Modi ji का vision है to control sickle cell, और उस vision के लिए हम सबको मिल के align होना है. He has put sickle cell in the priority list for us to, fight sickle cell. So we all have to do our job. Now, all these, together with the NGOs, all the pediatric hematology doctors, obstetrician and gynecologists, blood bank people, we all have to come together. And we have to, present our issues in front of the government, work with the government, because the government is the one which has the maximum reach. Involve the social media, involve celebrities, make pictorial diagrams, do a social media strong campaign, and reach out to every individual and say कि sickle cell का अगर एक mother को sickle cell है तो father का screening करें, so that we can identify that okay, both the parents are carriers. Can we prevent the birth of a child with a homozygous sickle? And if there is a homozygous sickle child who is born, right from very early age, we start, treating him so that he or she does not have complications. And, we see children 12 saal, 15 saal, 18 saal pe first time being diagnosed with sickle with both the bones are gone, avascular necrosis of hip, so many complications. That is because there is lack of education. Hai na? So we have to reach out to everybody and educate people.
Very rightly pointed out, sir, there is a lack of awareness, and if that lack of this awareness can come directly from the government, like earlier, for example, the government used to with the help of advertisements on radio, TV, or let's say before the movie starts. If we can do such kind of awareness, I believe, parents or the young generation, the going to be parents, will get all these things screening done before planning a child, and I think that is what is required right now to control the rate of sickle cell patients in our country. Very rightly pointed out, sir, and thank you so much for that thing. I believe this will also happen, but it will take a bit of time. So thank you so much for that answer, sir. So additionally, if you can answer that, what are the main challenges in SCD care in low resources setting, and what new treatments beyond hydroxyurea, transfusion, and transplant are being considered?
See, there were a lot of drugs that came up, but none of them have been really very promising. There was crizanlizumab, there was voxeltor, there was glutamine. So many new disease modifying agents had come, which could be used, but none of them really made a big impact. The cost was huge and the benefit was not much. So ज्यादा दवाइयां नहीं है हमारे पास, तो अभी भी मेनली अभी हम हाइड्रोक्सी यूरिया ही ढंग से नहीं दे रहे. वी आर नॉट गिविंग इट इन द करेक्ट डोज, वी आर नॉट गिविंग इट टू एवरीवन, वी आर नॉट एबल टू रीच टू द मेजॉरिटी. You know, I would still say that 70-80% of sickle cell patients don't have access to hydroxyurea, and they don't even know that it is a safe drug and it does not have complications, and you can give it for 30, 30, 40 years and still people don't get a complication of that drug. So the benefit of this medicine needs to be tapped. रिसर्च बहुत सारा करना जरूरी है, क्योंकि हमें और दवाइयां लेके आनी है. अगर हम इसको कर सकें, जीन थेरेपी, इफ इट कैन कम टू इंडिया, इट कैन बी डन इन अ सेफ वे. देयर आर लॉट ऑफ एडवांटेजेस ऑफ जीन थेरेपी ओवर बोन मैरो ट्रांसप्लांट. सो यू नो, एज का बैरियर उसमें नहीं है, क्योंकि बीएमटी जल्दी जल्दी करना है. अगर 12-13 साल के बाद बीएमटी करते हैं, देन द कॉम्प्लिकेशंस आर. So, you know, abhi at the moment we don't medicate hydroxyurea, prophylaxis, prevention from hepatitis B, hepatitis C, appropriate vaccination. Vaccination is very important. These patients from pneumococcal infection, typhoid, influenza, chickenpox can be very complicated in these patients. Meningococcal infections. Those important things. Transfusion areas where we are working, any drug are beneficial for these.
Dr. Kalra, your voice is not clear. It's breaking a lot. It's very difficult to understand. Hello, sir, can you hear me?
Medicines हैं. Can you hear me?
Yes, sir. Now it is a bit clear.
Can you hear me now?
Correct.
Yeah,
Yes,
so
I
what
can hear
I'm
you.
saying is that right now, mainly we have to focus on hydroxyurea, blood transfusion, and stem cell transplant only.
I think there's some error in his connection, but I believe we got it what he was trying to explain to us, that what exactly is the necessary thing at this point of time. Yes, Dr. Manas has joined us again. So,
Yeah, I think I would just want to say that there are not many options, not many drugs. The newer drugs, prizanlizumab, voxeldor, everything has not shown much difference in the life of in the life of sickle cell patients. But at the end, we have to just mainly work with hydroxyurea, blood transfusion, transplant. These will be the main things. Plus, also we have to, you know, vaccinate these patients. Vaccination is very, very important. So focus on vaccination has to be there. Early treatment of infections, prevention of dehydration. You know, these are the main focus areas for these patients, and not many other drugs that are beneficial at the moment.
sure. So, thank you so much. And Dr. Vinita Srivastava has also joined us. We just got to know that she was busy in a government program and got stuck because of network issue. Ma'am is here. Ma'am, can you hear me?
Yeah, I can hear you, Sibran.
Yes, thank you so much for joining, ma'am, and welcome to our show. I don't think that Dr. Vinita needs any introduction, but still, I'll introduce her to our audience. Dr. Vinita Srivastava is from National Health Authority, Ministry of Health and Family Welfare. She has been a pivotal in shaping the National Sickle Cell Anemia Elimination Mission. Thank you so much for joining, ma'am. Ma'am, directly my question to you is, yesterday was the Sickle Cell Day. So just want to know how government celebrated the Sickle Cell Day.
A very interesting fact. Thank you, Simran, for giving me this platform, because something to very interesting to tell you about that I am in Andaman today, and yesterday we had celebrated Sickle Cell Day over here in Andaman. That was the initial starting of Sickle Cell mission over here in Andaman, where Chief Secretary announced that we are going to start the sickle cell screening along with other screenings as well. So bouquet of screening for the Andaman people, which is now going to be initiated very soon. In 15 days time, we will draft the entire project, and CS has to approve it. And this has been done with the help of DHS over here and the ICMR. ICMR and DHS together have come up for this screening part. So it was very interesting, and I am so happy that I was a part of it, which was never ever thought of. It will happen in Andaman, but now it has started. So government of India is too much committed for the cause of sickle cell disease and others as well. So this is a commitment of government, I should say like that.
Thank you so much, ma'am. And we can, feel that excitement in your voice, how happy you are, what the government has taken, the actions and everything. Ma'am, one more question to you. That do you feel that we need more of CSR initiatives and collaboration in sickle cell management in India, apart from the government, what they are doing?
Yes, of course. I mean, one should come together. This is time like you people are doing is like Voice of Healthcare has initiated this. Something like that, we need to initiate all these activities through our CSR activity as well. Many of the people are here. Here also, the oil refinery which we have just founded, they have also said that they will support it. So I was very happy to hear that now everybody wants to join hand. This will be the only mission in the country which has a good convergence model along with the departments and as well as with the CSR activity.
Very rightly said, ma'am. And just before this, we were discussing that Dr. Manas Kalra said that we need more of bigger impact awareness session where government will pitch in, more of pictorial awareness, more of celebrities coming in promoting this. And I believe this is going to gradually happen, like what you just explained to us.
I
Thank
feel Simran, I just feel ki what Manas has said correctly said, but the concern is our celebrities rather than my saviors. I should say my doctors are my saviors. They are the saviors. They should be protected like that. And other thing is that those who have gone through the sickle cell problem, I'm those the warriors of sickle cell. They should be protected well because they should be the storytellers and they should know how these things happen and how they have come over it. So that is the biggest thing which we can do.
Very rightly pointed out, ma'am. They are the real heroes. They're the real person who understands the pain behind this as they deal with their patients every day. And they are
Yeah.
putting all the hard work behind that. Thank you
Thank
so
you.
much for joining, ma'am. Thank you so much. I request if you can stay back so we'll proceed with the
I'm here.
discussion.
Yes, yes, please proceed.
Thank you so much,
If my
ma'am.
network, sorry, if my network goes, so I apologize for that. But till network is here, I am there with you all.
We understand, ma'am, and thank you so much for joining. Thank you. My next question is to Dr. Gopal. Dr. Gopal, what are the common adverse transfusion reaction observed in patients with sickle cell disease, and how can they be effectively managed?
Yeah. I initially mentioned about the extended phenotyping. That is because of the most common adverse reaction we see in the sickle cell patients is the development of the allo antibodies. Because of the frequent transfusion and the extended phenotype mismatching between donor and recipients, there is the probability of the development of allo antibodies against minor blood groups, you can say KL, KIT, Duffy, MNS, etc., is very much higher in sickle cell patients. And because of this development of allo antibodies, there is, I already mentioned previously also, the difficulty to getting blood for those kind of the patients. Then, if they do not get those kind of the matched blood in that case, or in periphery, there is no facility to check the allo antibodies. And if they got transfused with those kind of the blood, there is the probability of hemolytic transfusion reaction is increased in these patients. After transfusion, there is increased hemolysis in patient, and patient hemoglobin will get down in place of the increase in after transfusion of the blood. The second common adverse reaction in these patients are the febrile non-hemolytic transfusion reactions. This is because of the WBCs present in the blood, PRBC and whole blood, that cause some febrile reaction in patients after transfusion. And that is also we can prevent it by the leukoreduced blood. In leukoreduced blood, we remove the WBCs from the PRBCs, and then after transfuse, the febrile non-hemolytic transfusion reaction which reduced in certain amount in many patients. But again, the availability of this liquid-reduced blood is also is quite challenging in the peripheral area. The third one, you can say the common adverse reaction in this kind of the patient are the hyperhemolysis. The most common hyperhemolysis present in sickle cell patients as compared to the other kind of the patients. In hyperhemolysis, the after 7 to 10 days hemolysis start in this patient, and in the 7 to 10 days, even transfused blood along with patient's own blood both got hemolyzed, and patient hemoglobin will get down, and patient got jaundice in that way. Then in long-term complication, you can say the common is iron overload because of the multiple blood unit transfusion. After single unit of transfusion, there is 200 to 250 milligram of the iron is close to the patient. And after multiple unit of transfusion, this iron got accumulated in patient's body and iron overload can lead to that. Where yes, there are the availability of iron chelators in the market, but that also the cost of these iron chelators and effectivity of these iron chelators is also very less in that way. Then other the common adverse reaction is transfusion transmissible infectious disease like HIV, hepatitis B, hepatitis C. This kind of the infection is can be transmitted through the blood transfusion. And if there is not a proper testing facility available in peripheral like the ELISA testing, chemiluminescence, or nowadays the nucleic acid amplification testing is come up. By this testing, we can reduce much amount number of the transmissible infections in these patients. But if these facilities are not available in the periphery, there is the transfusion transmissible infections are got increased in this kind of the patients. So these are the common adverse reactions. Other than there are the many other transfusion related adverse reactions like transfusion related acute leg injury, circulatory overload, or hypertensive transfusion reactions, allergic reaction, bacterial infections is common. Those kind of the infection also.
Thank you so much, Dr. Gopal, for that answer. I would like to ask my next question to Mr. Dongre. So you're secretary of NASCO, so you know what all things are going in ground and what all things are required. So how do you view the progress of national sickle cell elimination so far, and which area still needs greater focus to ensure meaningful impact among underserved communities and tribal communities?
Yeah, thank you so much. So mission mode is going really very excellent since last 2 years. Before that, also government of India was working for the sickle cell. But after launching mission, its speed increased for screening. So screening, I think almost 5 crore people screen in last 2 years. And what we are facing in a ground is that the lack of counseling, because when the people are screening, but in some places we found that they are not proper counseling to the to the trade people, especially uh, just the technician or ANM or ASHA, just they are labeling that you are sickle positive, but they are sickle trait. So the fear, the stigma creating loudly in the crowd of these communities that they have sickle cell disease, but they are the trait. So the proper counseling, we are lacking about the proper counseling. So we required at least a one counselor in each and every district where the sickle cell is more prevalence. The counselor will play the main role of eliminating sickle cell disease as early as possible, because the counselor will be the bridge of patient and the doctor, patient and the hospital, and the counseling he will do for the treatment purpose also, and to reduce the stigma. Because in mission mode, if without counselor the mission will go, only screening will happen. Otherwise the patient will not aware about the disease. Patient will not aware about the medicines, and this the patient will not aware about the counseling. So they will not go to screen their family also. So in this point, we aggressively need a counselor in each and every district places. Thank you so much.
Thank you so much, sir. I believe Dr. Vanita has left the session because of some network issue. I would like to know I would like to ask my next question to Dr. Manas Kalra. So, how important is it to accurately, differentiate the sickle cell disease from the thalassemia and HBE during the screening, and what are the challenges in doing so? So, you're on mute, sir.
It's very important to give a right diagnosis to a patient, है ना? So if you are Simran and I call you Gautam, you will not like it. If I call Gautam as Simran, Gautam will not like it. Same way, if you call me Gopal and you call Gopal as Manas, we are not going to be happy. Same thing is with the disease. How can we label somebody who has sickle cell? We can label him as thalassemia. That's wrong. The treatment is different. The role of hydroxyurea in thalassemia is not as much as the role of hydroxyurea in sickle. So the treatment is completely different. The way we approach the symptoms of the patients is different. The counseling is different. So similarly, when we are testing them, suppose we say, okay, that the parent has E and the other parent has, say, beta, but somebody has labeled them as sickle, and you go for antenatal testing and you are trying to look for sickle, and you will say, oh, sickle is not there, but actually the parent had E and did not have sickle. So you are trying to look for a problem in the baby which the parents did not have. So this can have disastrous outcomes, because you will say, oh, the baby does not have sickle, but the baby will get E because you did not look for E. So labeling is of the disease, of the name, is very important. The treatment differs, the future counseling differs, the antenatal testing differs. So it's very important to make the right diagnosis. Now, also we know that sickle cell is more common in the Vidarbh area, in the central area, the central belt of India, where sickle is much more common. Thalassemia is again, different kind of a population. North it is common, Punjabis, Gujaratis. There are areas where thalassemia is more common. Now, thalassemia is more common in the northeast, in Bengal, Assam. That area we see thalassemia. So, but because of migration, because of marriages in between the communities, because of people going everywhere for their jobs and everything, now we even see a little bit, some amount of sickle in Delhi, which whereas earlier we never used to see much sickle. Now we see patients, once a month we see few patients with sickle. There, many of them are migrated to Delhi, or who are just working here for some time. So, area-wise distribution I understand, but then making a right diagnosis, right treatment is very essential. So, correct diagnosis before first transfusion. If we do a HPLC, we'll be able to make a correct diagnosis. If transfusion has been given and then we have to diagnose, still we can make a diagnosis. Genetic testing is also very helpful in making a diagnosis for these cases.
Thank you for that answer, sir. And you rightly said we need a right labeling so that we can proceed with the right treatment plan. And that's very, very rightly pointed out. My next question is to Dr. Gopal. So, how can newborn, premarital, and facility based screening program be scaled to ensure nationwide coverage and early intervention?
Actually, newborn screening, yes, it is quite important. If we can start the newborn screening, even antenatal screening, we started of the parents, and then we can prevent the birth of those kind of the double S sickle cell homozygous patients, or we can modify their gene in the before birth or at the neonatal stages. It can prevent and the future life of the whole that individuals, because it's completely depend on the what kind of the sickle cell they have and how they can grow and what kind of the facility they are available. So if we can identify it in the newborn stages or the antenatal stages, we can quite save his quality of the life in the future. So there are nowadays many facilities are available for the by the chorionic venous sampling or amniocentesis. We can antenatally screen the mother or fetus inside the mother, and we can identify that what is the probability of the sickle cell disease in this kind of the patients. As well as in the newborn, there are nowadays molecular testing is also available in the many centers, and easily we can screen those patients. As well as on the point of care testing is also available. HPLC testing is available there. So that kind of the screening will help in the identify the incidence and prevalence of the disease, as well as to prevent the future life of those kind of patients.
Thank you so much, Dr. Gopal, for that answer. And now with this, we have come to close to end of our session. I would like to take closing message from each panelist here. Mr. Gautam, I would like to start with you. So if you can give us a closing message on this special session awareness.
Yeah, yeah. Thank you so much, ma'am. My address will be that about screening. Screening is very important part. So each and every young person should know their genotype uh, to prevent the new birth of sickle cell disease, thalassemia, because this is the only way by which we can stop the new birth. So today is my message to the young people that please do check their genotype and save the future of India. Thank you so much.
Thank you so much, sir. Dr. Vinita is here. Ma'am, we are taking closing message, but I would like to know from you that what system are being built to sustain SCD care beyond our elimination mission, that is 2047, and should other hemoglobinopathies like beta thalassemia be, be
See,
integrated into national efforts at a similar scale?
it is already there. If you see Simran, if you see the portal of sickle cell, it is the thalassemia has been added, and also hemophilia has been added. So already government is committed for both the disease. It's not only one that sickle cell mission has been, but the sickle was a basically a torch bearer for all of us to come up with other disease which are equal to the sickle cell disease, and they have the same issues. So already government has taken up. If you see the first guidelines of India in 2016, it was only the hemoglobinopathies which we talked about. As the tribal ministry took it up, the problem which we saw was mostly in tribal areas, but it is not only in tribal areas but in other areas as well. So now the government is also taking up these diseases like thalassemia. They are taking it up. Hemophilia, they have been taken up in the same portal. So this makes a difference. And now the screening in all the parts has been initiated. It was already there, but now it has been aggravated. I can say that. So this has been taken up.
Also, ma'am, how important is the inclusion of advancements, AI-based technologies with capabilities of digital reporting and timely screening of SCD under the mission and management, ensuring it is accessible to all remote settings also?
Important question, because see, through AI we are getting the real time data. If you see the SCD portal, it's already there, and you can see the real time data. So the point of care, basically the point of care which is there, which also basically give the real time data as well. So the data is immediately uploaded on the cloud. That is one thing. And 35 tests had been approved by ICMR. It's not one, two, or three. It's like 35 tests has been approved by ICMR, and they all have. I mean, leaving some apart, they all have this facility. So the real data can be generated easily. So now the time is that when we project across the world, it is like that real time data is there in India only, and that is, I mean, we salute to our senior leaders and officials, everybody who took up this initiative.
Rightly said, ma'am. And a closing message from you for this session on the on sickle cell awareness.
My concern is that everybody should come forward, whosoever it is, not only the organization who has to come forward, but the all the school, colleges, the teachers, the doctors association. Everybody should come forward for this mission. Once we join hands, nobody can before 20. It is, I mean, it is said that we have to eliminate before 2047, but we will definitely do it before if we all join hands and do it together. So prevention is one aspect which we are already up to. Now the time is that we all join hands together and do, yes, let's make the mission successful for the country.
Rightly said, and thank you so much, ma'am, for this message and for all the awareness and expertise you have shared with us today for the session. I understand you are stuck in a very difficult situation where network is the biggest problem, but thank you so much for joining in this situation as well.
Thank you so much. Thank you all.
Thank you, ma'am. Dr. Manas, I would like to have a closing remark from you as well for the session.
I would like to say that let us try and diagnose patients with sickle cell anemia as soon as possible. Let us increase awareness so that these children are not diagnosed at the time of complication. They should be diagnosed early. Let us all try that, hydroxyurea is made available for every child with sickle in every corner of the country so that they have the access to this drug, which decreases their side effect, which decreases their symptoms and decreases the morbidity in these patients that they suffer, decrease the pain, because they live with pain, and we don't want anybody to live with pain. We want them to live in with a good quality of life. Let us try and put in all efforts that every child with a homozygous sickle who is symptomatic, who has poor response to hydroxyurea, undergoes a stem cell transplant if he or she has a match sibling donor. I think these three things, if we are able to achieve, this would really bring up the quality of life of children who are suffering from sickle cell. Also, let us all pledge together to prevent the birth of children with thalassemia and sickle cell disease so that, not many people have to suffer in this life and have to undergo these difficult treatments, these challenging therapies, and to, bear the burden of a lifelong disease. Thank you.
You rightly pointed out, San, and thank you so much for the closing remark. I would like to know closing remark from Dr. Gopal, sir. If you can share your closing message with
Yeah,
us.
yeah, thank you so much. So, in perspective of the transfusion, I would like to say, like I mentioned, there is the quite difficulty in the availability of the blood and blood products for this kind of the patients. Despite having so much of the blood centers, that tribal area is still lacking of the blood is there. So it is not necessary to open a new blood center in that way. We can open a blood storage center, so you can easily store our blood there from the tertiary care centers. You can take it and store there, and as and when required, you can transfuse to those kind of the patients, as well as availability of the extended phenotyping. I can say you cannot need to open it in the each and every blood center to start the facility, because yes, there is so much cost involved in this kind of the facility. You can do a centralized testing in you can make a center of excellence in that particular area, in that particular region of the 50 kilometer, 100 kilometer, wherever possible, to send the sample easily, and you can take the facility centralized for the all kind of the blood centers nearby to there. And by this centralized effort, you can provide the safe blood to these patients. Yeah, thank you so much.
Thank you so much, Dr. Gopal, for that closing message. And with that, we have come to end of our session. I would like to thank all of our esteemed panelists for such an insightful and thought-provoking session. From challenges in accessibility to the promise of advancement therapies, and from policy framework to community participation, we have discussed all into this discussion, beautifully reflected the complexity, urgency, and opportunity surrounding the sickle cell disease in India. And with this, we wish that slowly and gradually, like the mission is to eliminate sickle cell from our country by 2047. And like Dr. Vinita said, it will be done earlier than that. And we believe so. We believe in our system. We believe in the policy which is being taken care and implemented by our leaders. Thank you so much for joining and sharing, spreading this awareness with us.
Thank you.
Thank
Thank
you.
you so much.
Thanks.
Thank you so much. Thank you so much.
Thank you so much.
Thank you so much.